A 65-year-old patient with hypertension and type 2 diabetes on some medications is admitted for severe cellulitis that did not respond to multiple rounds of oral antibiotics. The patient is found to have an elevated hematocrit to 51% on admission labs. What is the most likely cause? PV, dehydration, the SGLT2 inhibitor, or chronic hypoxia? Today we're going to talk about SGLT2 inhibitor-induced erythrocytosis. Well, what is it? When you're on an SGLT2 inhibitor, you actually end up getting renal hypoxia signaling, which increases your erythropoietin levels, and the medication leads to natriuresis, and so your hematocrit ends up increasing. We should juxtapose SGLT2 inhibitors and polycythemia vera, because differentiating the two of them can be very helpful. We just reviewed the mechanism for how SGLT2 inhibitors cause erythrocytosis, and remember that for polycythemia vera, a JAK2 mutation will lead to clonal expansion. When you look at the EPO levels, it will be normal or high if they're on an SGLT2 inhibitor, and low in polycythemia vera. When you have more hematocrit, an elevated hematocrit, your blood viscosity risk can go up. If they're on an SGLT2 inhibitor, that risk doesn't really present itself unless the hematocrit is greater than 55%. And in patients with polycythemia vera, it's elevated regardless of the hematocrit. In terms of management, you don't have to do anything for SGLT2 inhibitors unless it's extreme. And for polycythemia vera, you need to do things like phlebotomy or cytoreduction through hydroxyurea or monoclonal antibodies. So who is at risk? A couple folks. A patient with baseline low normal hemoglobin can end up having larger increases in hematocrit. Patients with CKD actually have an exaggerated EPO response when they're put on an SGLT2 inhibitor. And finally, if you have just a little bit of iron, so iron deficiency anemia. Now you might imagine many patients have CKD and a baseline low normal hemoglobin because of it, and then can have iron deficiency. So they have all three risk factors. So it's important to realize that in patients with ESRD or CKD, they're even at higher risk. Now the typical hematocrit increase that we see when you start someone on an SGLT2 inhibitor is about 2 to 5%. If you see that number, you can probably attribute it to the SGLT2 inhibitor. However, if the hematocrit goes greater than 55%, that's not a good thing, and there's increased risk of blood viscosity and all the things from that. So when you're thinking about the clinical significance and potential risk, this is beneficial because you actually increase your oxygen carrying capacity, and that can contribute to the many cardiorenal benefits that we're seeing in SGLT2 inhibitors. The risk, of course, ends up being related to hyperviscosity, and if your hematocrit is really elevated, there's maybe concern for thrombosis, but we don't really have clear evidence of that in the literature just yet. So when approaching this, if you see an elevated hematocrit, you need to pay attention to it. If it went up by greater than 2 to 5%, just watch out and monitor it periodically. If the hematocrit is greater than 55%, you really should be thinking about doing a polycythemia vera workup. And then you have to decide if you're going to continue or discontinue the SGLT2 inhibitor. And so if things are looking good, continue. And if it's not looking good, meaning the hematocrit is greater than 55%, or the hematocrit has gone up more than 5%, you may need to stop or dose reduce, depending on the indication for the medication in the first place. So to summarize, remember that SGLT2 inhibitors raise hematocrit via erythropoiesis and hemoconcentration, and the normal change is 2 to 5%. Juxtaposing it to polycythemia vera is very important, and you can see that there, where in PV, a JAK2 mutation leads to clonal expansion, your EPO level is low, and your blood viscosity risk is elevated. Risk factors for developing SGLT2 inhibitor induced erythrocytosis are CKD, baseline low hemoglobin, and iron deficiency. And finally, if the hematocrit is greater than 55%, you should assess for polycythemia vera and causes of chronic hypoxia, and stop or dose reduce the SGLT2 inhibitor.